There are many industries, right? There's health, there is what so many industries are the industrials. So which is the safest industry in the world is aviation. Aviation. Aviation is the safest of the whole world. And why is aviation the most safe? If you see, there are millions of flights. In an average day, millions of flights with millions of people inside those flights. Okay, going, and you hardly hear of a flight going down, right? You hardly hear of a crash. If you look at it just in India, our airport may be having 700 flights in a day, more than that. 700 flights, and look at the number of people each flight may be carrying around 100 people per flight, 150 people, and look at that how safely they fly from place to place. You are actually able to put your life in their hands and go up to the sky, isn't it? Isn't it? Huh? So it is so safe. And why is this industry so safe? This industry is so safe because all of you have gone by flight?
Yes.
Yeah.
So have you all, when you attend, go climb up the flight, what do you all see on the left side? When you're just climbing up the staircase, on the left side, what do you see? You see the cockpit, right? So in the cockpit, what do you see? What do you see them? Anytime going, they are always having a paper in their hand.
Yeah.
They're always having a paper in their hand. When a person comes from outside, a hostess is actually telling someone, again she has a paper in her hand. The person who is coming from outside and telling the bags have been loaded and not loaded or whatever, he again comes and he takes a paper. You see that? So everyone in the entire unit, right from the time you enter the airport to the time you exit the airport, will have multiple checklists. Okay, and it is that checklist that has actually improved the overall safety of the aviation industry. So as intensive care doctors, sometime in 90s, we realized that our ICUs are not safe. And that is the reason that a very famous professor from Brussels actually went ahead and put up this mnemonic called as Fast Hug BID. It was called Fast Hugs. It was started as a Fast Hug, and it came out as a very beautiful article in the papers in the intensive care journal saying that give your ICU a fast hug, give your ICU patient a fast hug daily. That's how it came. That's how the Fast Hug mnemonic came in. So so this manifesto has to be followed, and that is the reason that in our ICU sheets we've actually put Fast Hug over there. Okay. So what does this fast hug is basically is for these ventilated patients usually. When you say fast hug, it is for the ventilated patient. Okay. Each of these topics itself is a big topic. But some bullet points we will go through right now. Okay. So the first F in that is what? Feeding. So feeding means you need to feed your patients, okay, daily. Unless the patient has got reasons why you cannot feed. And we know the reasons could be intestinal obstruction, could be gangrene intestine, could be intolerance to feed, hematemesis. These are some patients where there are contraindications and we say we don't feed those patients. But largely every patient should be fed. You feed lesser to begin with and then you reach goal in say 5 to 7 days. You feed less to begin with and then you reach goal in 5 to 7 days. This is what is feeding. You start at the start of feed and then slowly go up. It's important to do feeding, and why is that so? And when you say feeding, we're talking of enteral nutrition. When you're saying feeding, we're talking of enteral nutrition. Why are we talking about why do you think enteral nutrition is better? It has got a lot of reasons why enteral nutrition is better, because that's what's physiological. It's more physiological. We don't eat via our vein, we eat through our mouth, right? As it goes inside, it causes some improvement in gut-associated lymphoid tissues. It actually prevents gut translocation of bacteria. There are a few things that come in with enteral feeding that is very important. So, enteral feeding. So, of course, it's a topic on its own itself, but every patient needs to be enterally fed. Okay, fed enterally. Now, of course, initially the thinking was parenteral nutrition is dangerous. It's no longer like that, because initially when they used to give parenteral nutrition, it used to be associated with CLABSIs and other side effects. But now, since our practices of central line insertions have improved, we now don't have CLABSIs, so we could say that even enteral and parenteral are kind of equivalent. But looking at the cost itself, we would say enteral would be better. Clear? So it has some physiological rationale to give enteral nutrition. But F from the Fast Hug says you need to feed your patients, and that is why when you are actually looking at your patients, say 3 or 4 days later, you should be saying what should be the feeding. Remember this. Tomorrow, your patient is not going to be a patient, he is going to be a patient who has come and admitted into you, which is personalized. We cannot say that patient number, bed number 1, bed number 2 and bed number 3 will have the same feeding schedule. It can't be possible. It can't be possible. And that is the reason that you have to personalize. Okay, tomorrow the patient will not say just treat me like a patient of malaria. Treat me like ABC of malaria. My name is ABC. That's how personalized it is. That is why your patient should have a certain calorie, a certain protein and a certain fluid requirement. On an average, the calorie requirements would be 25 to 30 kilocalorie per kilogram. On an average, the requirements would be 25 to 30. Of course, you are in a unit that is very high-fi. So, otherwise, your requirements would be 25 to 30 kilocalorie per kilogram per 24 hours. When I say per kilogram, it is actually the ideal body weight, actual body weight. Okay, Clear on this till now? When you say proteins, the protein requirements on an average is 1.2 to 1.5 gram per kilogram. The requirements, so each guideline, so there are multiple guidelines. So tomorrow you want to read some paper, you want to read some article, you have to, in nutrition segment, there are 3-4 guidelines that you should allude to. One is the American Society of Parental Enteral Nutrition Guidelines, ASPEN. Okay, where the requirements will be 1.2 to 2 gram per kilogram of proteins. The other one is ESPEN, ESPEN, European Society Parental Enteral Nutrition Guidelines, which will give you 1.2 to 1.5 grams per kilogram. Okay, and the other one is Canadian Nutrition Practice Guidelines. Of course, the Indian guidelines are also there, but these are the 3 famous guidelines that have come out of research for a long time. And these guidelines are updated every 3-4 years. 2019 was the latest guideline change in SPEN. Okay, clear on this? Clear on this? Protein requirements, fluid requirements. Every patient in the ICU, of course, fluid is personalized, but on an average, the fluid requirements will be 30 to 35 ml per kilogram. 30 to 35 ml per kilogram. This is the average fluid requirements. And if you want to really make it even more personalized, the Holiday-Segar formula comes in place. What is the Holiday-Segar formula? Anybody?
4:2:4.
Yeah, what does that mean?
First 10 kg,
4 ml per kilogram. Second 10 kg, 2 ml per kilogram. So say the patient is 25 kilos, so it will be 40 ml plus 20 ml plus 5 ml. That is 65 ml per hour. That is Holiday-Segar is for per hour. Holiday-Segar is for 4 to 1. 4 ml per kilogram for first 10 kilos, 2 ml per kilogram for the next 10 kilos, and then 1 ml per kilogram for every kilo thereafter. The Holiday-Segar formula. Okay, so that is per hour requirements. So don't just start a person on 30 ml or 40 ml. It has to be per hour requirements, which has to be calculated like this, which is the ballpark figure usually. Clear? The overall requirements for of fluid are 30 to 35 ml per kilogram per hour, with the correct understanding that every rise of temperature of more than 1 degree above normal will require 150 ml of fluid more for 1 hour. So for example, if the patient at 9 o'clock had fever of 38 degrees and at 10 o'clock was again 38.3, 10 o'clock is 38.3 degrees, it is 1 degree above what is normal. You will actually give the patient an extra 150 ml. That is how you are going to look at. Okay, that's the insensible loss you have to add to this particular schedule. Right? So we are personalizing our fluid management very well, but this is the ballpark figure. So if you have a patient who's coming with malaria and you're actually, patient is having multiple episodes of fever and it is going 103, 104 degrees, I want to be conservative in my fluid management, but I have to keep this in my mind that I'm losing 150 ml per hour, that is temperature 1 degree high. So if it's 104, you can imagine the number, it's 1 pint 500 ml that is going down. If it's 104, it's at least 1 pint, that's 500 ml that is going down. So you must remember this on the back of your mind, that you have to ensure that you give that fluid. Okay, this is about feeding. Clear on the feeding? When you're writing on feeding, the end result is not just writing feeding. You are writing whether the feeding is tolerated or not tolerated. When I say feeding is tolerated, it means that the patient is having no problems. If it's intolerated, it means either the patient is having abdominal pain or is having a large volume gastric residual volume. When I say large volume, means more than 500 ml. More than 500 ml, I will tell them to take measures. Okay, so that is intolerant. Third is when there is intractable diarrhea. What is the meaning of diarrhea? More than 3 loose stools in a day. Okay, that is more than 3 loose stools in a day. Clear on this? Clear on this?
in that also to compensate for the loss, no?
Yeah, no, we will come.
Yeah.
Let's not get into that. As of now, just much. Huh? The next step is A. What is A? A stands for analgesia. Okay. When I say analgesia, which are the analgesic drugs, Sakib? Which are the analgesic drugs you know of in the ICU?
Sir, PCM, fentanyl.
So the group is acetaminophen group. Then you have the synthetic opioids. Then you have morphines and things like that. And NSAIDs, right? So we usually don't prefer to give NSAIDs in the intensive care unit, but the rest of the drugs are what you're going to use. But the point is analgesia to be titrated to the score. You have to score the analgesia. You have to score the analgesia. So you can't just write patient is on PCM. You are supposed to write whether the patient has got PCM to score, whether it is VAS score. The score is visual analog score. The score is visual analog score. So you are supposed to write that the patient is on PCM and the VAS is 1 on 10, 2 on 10, 5 on 10, 10 on 10. That has to be there in your sheet. Okay, otherwise that analgesia is not right. Now the visual analog score is basically a recall from the patient. The visual analog score is a recall. You're asking the patient, 10 में कितना है? That's so there are two types of score. Visual analog score, you're looking at the patient and telling, okay, ऐसे ऐसा कर रहा है, ऐसे ऐसा कर रहा है. That is visual analog score. But there is ladder score also. 10 among 10. Among 10 what is? So you can tell the patient out of 10 pain कितना है आपका? 5 है, 4 है, 3 है, 2 है, 1 है. So that has to be done. So paracetamol score 5 by 10. ऐसा आना चाहिए. So now I realize that no, he's having pain. See, patient is coming here so that he has no pain. If the patient has pain, then you are not a good doctor. It's as simple as that. You are not a good doctor. If the patient has got pain, भले ही तुमने कितना भी हेमोडायनामिक्स तुमने कंट्रोल किया हो, भले ही तुमने कितना भी उसका क्रिटिकल स्टेटस कम किया हो, if the patient has pain, you are not a good doctor. Our first thing that we have taken our oath is to reduce pain. Pain and suffering. The first thing that we do, right? So you have to ensure that the VAS score remains at low, very very low. When 1, 2, 3, it has to be that. It cannot be 5, cannot be 7, cannot be 10. It's wrong. It's very very wrong. Okay, you have to ensure that the pain relief is there. So analgesia has to be scored with respect to a pattern. You have to tell what is the scoring. So you cannot just write patient on PCM. For example, you have a patient who's on fentanyl. Okay, so you should be able to ask what that is, whether the pain is reduced or not reduced. And what we know in the intensive care is multimodal analgesia is better than unimodal analgesia to prevent side effects. So multimodal analgesia. That means I will not use one group. I will use multiple groups. Maybe I'll add a tramadol. Maybe I'll add a paracetamol. Maybe if possible I'll add an NSAID. I'll add a opioid. It has to be multimodal. I can't just keep increasing the fentanyl. That is wrong. That is completely wrong. Multimodal, multi-route. Multimodal, multi-route. So maybe you may have a patient who's having a rib fracture or fentanyl. I put an epidural. And I give an analgesia to the epidural. Are you understanding this? Analgesia. The next step, is S. What is S? So no, the S actually for a ventilated patient stands for sedation, vacation, and spontaneous breathing trial. The S in the fast hug for a patient who is mechanically ventilated stands for sedation, vacation, and spontaneous breathing trial. We have changed it in our patients who is not ventilated to say whether he slept well. Are you understanding? He slept well. But otherwise, it is sedation, vacation, and spontaneous breathing trial. But in our ICU, what you will write? Sedation, vacation is given or not given. Okay. So we plan sedation vacations in the morning hours. We never plan sedation vacations in the evening hours. And why is that so? Why do you feel that is so, Atul? Why is that so, Amit?
More people around.
Exactly, because when the sedation vacation is given, patient can become agitated. Patient can tug and pull on lines, remove and harm himself or herself. So sedation has to be done in the morning hours. In the morning, sedation vacation has to be done in the morning hours. Very very important. Okay, and why is that important to get sedation vacation to be done?
To assess neurology.
First, to assess neurology, whether the neurology is intact, no problem per se. Then,
to prevent that.
How does it prevent VAP?
It will so reflexes means
No.
secretion.
How do you prevent VAP?
So
Keep 30 degrees.
How will it prevent VAP? How does sedation vacation prevent VAP? So sedation vacation prevents VAP because it increases the rate of extubation faster. It reduces the duration of mechanical ventilation. Sedation vacation reduces the duration of mechanical ventilation. Since it reduces the duration of mechanical ventilation, if patient gets extubated faster, they have chances of VAP lesser. समझ में आ रहा है? So sedation vacation is supposed to be given because it reduces the duration of mechanical ventilation. And since it reduces the duration of mechanical ventilation, in effect it reduces the duration of VAP, incidences of VAP. समझ में आ रहा है? Sedation vacation. Sedation vacation. Clear on this? At the same time, a spontaneous breathing trial. Now, a spontaneous trial is defined as a 30-minute window to approximately 2 hours, from 30 to 2 hours, where the patient is on a T-piece or the patient is on very small pressure support equal to 6 and a PEEP of 4 or 5. This is what is a definition of a spontaneous breathing trial. Every patient needs to be getting a spontaneous breathing trial in order to assess whether we can extubate these patients. Okay, readiness to wean. So obviously you need to figure out what is readiness to wean. That's a different topic itself. Readiness to wean, readiness to extubate, all that comes differently. But every patient who is on a ventilator, if not, so which are the patients in which you will not give the spontaneous breathing trial? If there is real contraindications to do that. For example, if the patient is on very high PEEPs, patient is on 15 PEEP, 14 PEEP, I can't go into a spontaneous breathing trial because if I do that, the patient will very badly decompensate on the ventilator. So if the patient is very high PEEP, patient has very high FiO2 requirements, patient is a prone ventilation patient, and in such patients, I don't want to give a spontaneous breathing trial. You understand? Or there's a surgical reason why they're saying don't do it. They don't want to move something on this rhino there. This is one of the reasons where you will not give a spontaneous breathing trial. Clear on this? Or clear on this? But otherwise, every other patient demands a spontaneous breathing trial. Your reason to importance over there is at this moment is you have to be present to ensure that the patient does not accidentally extubate. Patient does not accidentally extubate because that can be disastrous. That's why a spontaneous breathing trial is conducted in supervised conditions inside the intensive care unit in the morning hours and not in the evening or the night hours. Clear? Spontaneous breathing trial. In non-ventilated patients, what are we looking at? Has the patient slept in the night? Sleep is very essential and documented that healthy sleep, for a person to be healthy, you need 7 hours of sleep. It is documented that patient requires, all of us require around 7 hours of sleep so that we can actually have a good recuperation, right? Now critically ill patients are a different situation. What is the situation? They are in an unknown environment. When you go to a hotel also it is so difficult to sleep. If you go to a hotel it is so difficult to sleep. You have to sleep because you are in an unknown environment. Okay, there are lights that are on most of the times. The lights have to be switched off in the night. It have to be switched off in the night. There is no doubt about it. For sleep hygiene, this is called a sleep hygiene. When in the night the lights have to be switched off. There has to be pin drop silence. What is the meaning of pin drop silence? 45 decibels. That means if you drop a pin also, I must be able to hear it. It is less than 45 decibels. Okay, our requirement in the ICU is 45 decibels. What is the requirement in the ICU?
45 decibels.
What is I'm speaking at now?
Above
100.
100.
I am above?
100.
Okay, I am above 100. Okay, so when I am speaking at 100, this is loud. So when I say pin drop means if you drop a pin, I must be able to hear it. It's actually 45 decibels. It's supposed to be lesser than that. These are the guidelines. These are the guidelines. So what is the background of this? When you want the patient to sleep, we should not be making noise. We should not be making, none of us should be making noise. Our curtains make a lot of noise. Our doors make a lot of noise. Our AC makes more high noise. Our AC makes a noise of 45, a hum that you can't hear.
In the morning.
Yeah, it makes noise. So it's important that you take care of this noise. Clear on this? Clear till now? On the noise. Not only that, you also need these patients. That that you give them, if they are not able to sleep, give them some sedation. Let them sleep in the night. Whichever patients you have sedated well in the night, next day morning they'll be very nice to you. They'll be very, very nice to you. They'll be like flowers to you. You actually have to sedate them in the night. It's very nice to actually sleep for them to sleep because they have a disturbed sleep-wake cycle. So that's why we normally tell our nurses that don't do investigations late night. Let them sleep. Don't do investigations in the morning if they are asleep. Don't do that. Keep the investigations towards the later part. Don't get up in the middle of the night and tell them to sponge them. No, don't do that. If the person is sleeping, let them sleep. Are you understanding? Let them sleep, okay? Because they have disturbed sleep patterns. It's very, very essential that you do that. Okay, so we are clear on the sedation now. The fourth is thromboprophylaxis. T. The T is thromboprophylaxis. All patients in the intensive care unit who are mechanically ventilated require thromboprophylaxis. Which are the other patients that will require thromboprophylaxis? Who's already on, say, something like a stroke? Therapeutic anticoagulation is going on. Those are those patients who require thromboprophylaxis. So these patients will require thromboprophylaxis, right? So thromboprophylaxis, what do you use? Do you use a Flowtron? What is a Flowtron? What is a Flowtron name of the company? What is that called as? No, it's not. It's called as
Pressure stocking.
No, it's not. What is it called as? So there are two ways that you can actually prevent DVT. One is mechanical, another is pharmacological. Mechanical and pharmacological. Okay, mechanical there are again many types. Of which mechanical, what we are using is called as pneumatic compression devices. It's called as pneumatic compression devices, of which some of them are called as sequential compression devices. Sequential compression devices means in sequences it actually gives compression. In sequences it gives compression. Okay, pneumatic compression devices. So when you are in the exam, when you are asked, you must be able to tell this, that this is called as pneumatic, not Flowtron. Flowtron is a company, not there in down south. It may be something else. Okay, so pneumatic compression devices or sequential compression devices. The other form is not sequential compression. It is called as graduated compression stockings, which we just now said as TED. Graduated compression stockings. Graduated compression stockings. When you are going to advise any of these mechanical devices, you should be aware what you are talking about. Okay, so graduated compression stockings can't be just like TED stockings. How do they, when you say TED, graduated compression stockings or TED stockings, what do they do? What does the nurse have to do? What does the nurse have to do? So first of all, when you are writing, apply a graduated compression stockings. Important things you must write is, are you going to give it as knee level or are you going to give it as thigh level? Okay, so knee level or thigh level, you have to decide that. You have to say whether I want to give knee level or thigh level. If it's very obese, I don't want to give, maybe I want to give up to thigh level. Okay, knee level and thigh level. And at the same time, what is the nurse supposed to do? The nurse is supposed to measure the calf circumference, measure the length, and then put it into an algorithm that they have. You go and see the algorithm, nurses may have it, which will say whether to buy XL, L or triple XL, because this graduated compression stockings are graduated to a certain pressure. So you can't use A stocking to B person, it has to be A to A only. You understand? Otherwise the pressures will vary. Clear on this? So TED stockings, they are called as thromboembolism deterrent stockings. That's the full form of TED stockings. Thromboembolism deterrent stocking, but they are essentially graduation compression stockings. Graduated compression stockings. Clear on this? So thromboprophylaxis. But the other part of the story that we want to use is pharmacological, of which you have heparin, just we discussed heparin, enoxaparin, fondaparinux, dalteparin. Any of these are the pharmacological prophylaxis. One of them have to be there. One of them have to be there. Okay. In cancer patients, both. Which is better? Pharmacological. What is better? Pharmacological. So I want to get off this Flowtron as quickly as possible. I don't want that device in place. Have you worn it any time? It's okay for 2 minutes, 3 minutes. After some time, it is very irritating.
Yeah.
It's very irritating. You sweating hota hai, it squeezes badly, you don't feel nice. You get cramp, it's not nice. So you want to do it only when it's required. Right? Okay? So ये हो गया thromboprophylaxis. Then the next is H. What is H?
Head up position.
Lady form we use for that thromboprophylaxis, because when I was feeling it. So it kind of gives you an idea whether
Patient requires it or not.
the patient requires just mechanical or because that's how the breathing
But we want to
0
give
to 1.
pharmacological. Yeah. Okay, so pharmacological is what we want to give. Okay, VTE. Then the next thing is
H.
H. What is H?
Head up position.
Head of bed elevation. Not head up position. Head of bed elevation. HOB elevation. Head of bed elevation. Right? So we want to elevate the bed, not the patient. Head of bed elevation. That's what the thinking is. Why you are saying head of bed elevation? because you have to go and see the angle of the bed. There is an angle on the bed. There's an angle on the bed that has to be maintained at a good amount. Okay. Now, what is the problem? What do you think the problem would be with head of bed elevation? What can be the problems?
Bed sores.
How? Why?
Because the pressure, the area, ischium पे pressure.
The complete pressure is on the sacrum. Since the complete pressure is on the sacrum at 45 degrees, there can be bed sores in that position, and that's why head of elevation is one is that is the situation. Second situation is you can't maintain that position. If you remain on that position, patient will slip down. So at 40, though classically 45 degrees head and elevation is not possible only. Because if you put the patient up, patient थोड़ी देर के बाद इससे हिलेगा, will not be able to sit on that because it's painful. And at the same time, your patient will move down. That's why they do all kind of things. They break the leg end of the bed. So that means patient is like this. Okay, that means there's a leg end also that is broken in the middle. That's why most of these beds have two breaks. Two breaks. We can break the head at two places. So the leg also gets elevated so that the patient doesn't slip down. Right? Patients in which will not use this leg break is the ones who have undergone peripheral angioplasties. People who have peripheral vascular diseases. In those patients, I will never and never use this leg break. Okay, that is not supposed to be done at all, right? In peripheral angioplasties, especially very compromised circulation, so take the surgeon's help before you do that, something like that. Clear? Head of bed. So how much should be the head of bed elevation? Why is the head of bed elevation required? The thinking is that it prevents aspiration. The thinking is that it prevents aspiration. That's the thinking. But ideally, if you think logically, if the patient's bed is elevated, there will be more aspiration. Logically, what would happen? It's going to aspirate faster from inside. So there is the evidence is not very clear. That's why we keep it at 10 to 15 degrees. That's why we don't keep it at 45. We keep it at 10 to 15 degrees head elevation. Right? Head of bed elevation 10 to 15 degrees is what we want to do. Clear? Right? Then this is H. Next is
Ulcer prophylaxis.
ulcer prophylaxis. So which are the patients that require ulcer prophylaxis?
All mechanically ventilated.
All mechanically ventilated patients.
Receiving
Receiving oral
Patient receiving anticoagulants. Therapeutic anticoagulants, not oral anticoagulants. Patient is receiving therapeutic anticoagulation. Then no. Patient who is having deranged coagulation. Patient is having deranged coagulation. And 4, patient who is on steroids. These are the 4 patients that require ulcer prophylaxis. No one else requires ulcer prophylaxis. Okay, no one else requires ulcer prophylaxis. Okay, these are the 4 classical indications for ulcer prophylaxis. Okay, once more if I repeat, ulcer prophylaxis is for mechanically ventilated patients.
Therapeutic anticoagulants.
Just hold on. So, among the ulcer prophylaxis, you have got multiple options that you have. What are the options that you have? You have PPIs, and you have coating agents like sucralfate. You have coating agents. Now, what has been said is that if your bleeding risk is high, you give PPIs. If your VAP risk is high, you give sucralfate. Okay, if your VAP risk is high, you give sucralfate. Okay, but if your bleeding risk is high, you give them PPI. That's why you might see sometimes I change it, I put sucralfate. Right? The reason is I feel the bleeding risk is higher here, so I mean the VAP risk is higher here, so let's put on sucralfate. You will notice that when I'm in the ICU. Okay, now so sucralfate, usually the incidence of VAP is lower with sucralfate as compared to PPI, because when you give pantoprazole, you are actually destroying the bacteria of the entire tract. You understand? The bacteria, the microbiome is changing, so there's problems over there. Right? Clear? So these are the only indications. It's a very wrong notion to say I'm giving an antibiotic, so I'll give an anti-ulcer medication. It's very wrong. It's very, very wrong to do something like that. It's not right at all. Clear? Clear on this till now? Ye ho gaya U. Then next is G. G is glycemic control. So when I say glycemic control, it just does not mean one solitary sugar that you're going to note or the morning sugar that you're going to note. When I say glycemic control means in my 24 hours, what has been my variability, what has been my peak and what has been my lowest. Okay, glycemic control. So the variability is very, very important. You can't have a person going from 70 to 250. It's very wrong to have something like that. That can cause the release of inflammatory mediators, cytokines, TNF-alpha, interleukins, and this may create overall morbidity to be very high. We don't want that to occur. variability is supposed to be taken care of. It has to be constant blood sugar between the ranges of 150 to 200. It has to be, unless we decide that we keep the patient on a higher sugar levels. But otherwise, in a regular ICU patient, we want to ensure that patient is between 150 and 200. Hypoglycemia is also dangerous. Hyperglycemia is also dangerous. Okay, in the community, hypoglycemia is very dangerous. In this, both are dangerous. Okay, clear on this? So glycemic variability. So when you come to glycemic variability, once you have a sugar that is more than 270, you are ensuring that you do half hourly sugar monitoring. When the sugars are more than 270, you're going to do half hourly sugar monitoring so that you can change the medicines to quickly get it back. Otherwise, your variability will keep on happening. Otherwise, your variability will keep on happening. So if your sugar you found as 300, you give, say, whatever say, if you're going at 3 ml, I'm going to give 5 units of insulin. And then I will repeat my sugar in 30 minutes. In 30 minutes. And I will see what's happening to that. And then give again, so that in the next 1 hour, I have controlled it. In the next 1 hour, I have controlled it. You're understanding what I'm saying? You don't do it in such a way that you're going to follow what the nurse is going to do. Okay? It depends on sensitivity. Every ICU should follow the protocol that we are using in Raheja. Okay, the same protocol has to be there everywhere. The same protocol has to be on the sheets on top, sheets in this. You follow the same protocol. Understand the protocol very well. It's very simple protocol, right? Glycemic variability. Clear on this? Clear on this? This is also the reason that when your sugars are alarmingly low, don't just go and give 100 ml or 25% dextrose. 100 ml or 50% dextrose. Don't do that because what will happen is your sugar goes 70 to 350. That's variability. We don't want that variability. Are you understanding? We don't want the variability. Give a small dose, wait 15 minutes later to the sugar. Just like how we're doing for high sugars, do it for low sugars also. You understand? Don't let the sugars go haywire from 70 to 350. It's wrong. Clear?
Yes.
Clear? So that is G, glycemic variability, glucose control in ICU. Okay, glucose control in ICU is what you're going to write. So you're going to write in your sheet, okay, patient's glucose is well controlled. The sugars range has been 150 to 180. One episode of hypoglycemia noticed, or one episode of high sugars noticed. Because as doctors, what you are thinking, is it the steroid that is causing it? Is it the stress hyperglycemia that is causing it? Is it my medicines that is causing it? Is my nutrition adequate? Is there more amount of inflammatory mediators that are occurring? Is there some drug that is causing this? I'm start thinking that way. My entire thinking will be based on that. Clear? Because glycemic variability can cause multiple problems. What can it cause? It can cause delayed gastric emptying. It can cause wounds to heal lesser. It can cause overall mobility to go down. It can cause increased bed sores. There are so many things that can occur if your glycemic variability is too much. There is too much. You understand? And that is the reason that I need to maintain my glucose very well. Okay. What is B?
Bowel and
Bowel and bed
bowel
sores. Bowel and bed sores. This is what is B. Bowel and bed sores. When I say bowel and bed sores, is the motions adequate? Remember this. Once you are more than 60 years old, no? You will be the most comfortable person if you can wear your pant and pass your motion. If you are wearing pants. Once you are more than 60 years old, you are going to be most happy when I can wear my pant myself and I can pass my motions. This is how it's going to be for all of us. Once we are beyond 65, 70 years old, this is what it's going to be. Our average age of our patients are that. Okay, so it's very important for us to ensure that there has been adequate bowel motions. Adequate bowel motions. If at that moment you find that there is not be adequate bowel motions, immediately do a per-rectal examination. Because more often than not, what are we doing in our ICU? We are actually giving diuretics. Most often than not, we are giving these patients diuretics. We are ensuring that their water are conservatively managed so that they are not in fluid overload. That's our basic thing always. We want to keep them equal to negative balance. So if we are doing that, most of our patients, what are we doing effectively? We are actually getting the colon to concentrate the feces. Colon is absorbing the water now because it's not getting water. So colon is absorbing the water. Colon, when it's absorbing all this water, what is happening? The stools are getting harder and tighter. Okay. Not only that have we done, we have removed the position of this patient. The patient is no longer passing motions sitting on a commode. He is now passing motions in the bed. So it is extremely difficult for this person to pass this motion. On top of it, you have put a ventilator. So your entire pressure comes when your vocal cords adduct. You are unable to adduct your vocal cords because your tube is in place. So you can't create the pressure also. You understand? He can't create the pressure. He or she can't create the pressure also to pass motions. So overall, it's a miserable situation when a patient is on the ventilator. It's a miserable situation when on the ventilator and is not able to pass motions. Very miserable it is. Okay, that is the reason that these patients should have a good bowel motion. and in the morning if you find that the patient has not had a bowel motion, act quickly on that. Act quickly on that. Give him whatever he needs to be given, change whatever needs to be changed, do a parental examination. Usually it's a parental examination needs to be done because there might be impacted feces. You take that off, let him pass motions. It will relieve a lot of distress. Okay, if he has loose motions, what are you supposed to say? 7 or 8 loose motions, you have to say 7 loose, that doesn't solve the issue. What has happened because of the loose motion? Has he dropped his electrolytes? Has his sodium gone haywire? Has his creatinine gone haywire? Has he developed a bed sore? Okay, these are the few things you're going to judge when the patient has got loose motions or altered bowel habits. Clear? Bed sores. Bed sores, when I'm looking at bed sores, what you must remember the classification of bed sores. So bed sores are classified as 1, 2, 3 and 4. This is the severity grades of bed sores. A simple redness that blanches is grade 1. That does not blanch is grade 1. Grade 2 is if there is skin peeling. Grade 3 is when muscles are exposed, and grade 4 is when bones are exposed. So even if there is a redness that does not go after pressure, that is a grade 1 bed sore. You are going towards grade 2 and grade 3. Very, very important that you see this. So every day when you are taking your round, turn the patient. Turn the patient. It's very essential to turn the patient. When is the right time to turn the patient? The right time to turn the patient is when the over is happening. When the nurses have come. When nurses have come, there is one nurse who has come from outside, one nurse is there in the night who is going to go. That is the time that you as doctors are on. That is why we try to coincide your rota with the nurse's rota. The reason to coincide with the nurse's rota is at that time there will be multiple staff that is there who can help you out to quickly finish the turning procedure. Out of 20 patients, you will have probably 10 patients who will have to turn, others will be conscious obeying commands. So those patients को turn करने का मतलब नहीं है. But those patients who have got incidents of bed sores are those who are not okay, they are just dying down, they are not neurologically fine, they've been there for a while. So that patient needs to be turned. So what is your duty? The first thing that you come, don't start writing notes, turn the patient. You know, first thing in the morning when the new nurses come in, don't start writing notes. Turn the patient because you have a nurse, you have got 2 nurses in that one patient. You understand? Turn, see that you're done. And you will be surprised to see that there will be many patients in which you will find bed sores. And then we'll have to take recommended measures for that. So what are the recommended measures to prevent bed sores? Glycemic control, adequate nutrition, negative fluid balance, albumin to be maintained, positioning every 2 hours. So you have a position clock. You have to follow the position clock everywhere. Position clock you have to follow everywhere. Okay, position clock. And then you have overlay devices. Overlay devices are what we call as air mattresses. There is underlay and overlay devices. What we have is overlay device. Why am I talking to you about overlay device? Because each one listening to this lecture needs to know how to decompress the overlay device. Do you know how to decompress it? Why do you need to know how to decompress it? CPR. If there is a CPR, you will not have any pressure that is going inside. That's why all of us sitting in this room should know how to decompress an air mattress. Do you know? How? One second, anyone, you know it?
It has a connection, we need to pull it out.
Yeah, so you have to see where it is, okay? You have to see where it is because there is.
What type is it? In some I've seen there is a switch of CPR.
So whatever we have, so, you have to ask us a pull. You pull it, mostly everyone has a pull. Open it and within 3 seconds it becomes fine. 3 seconds. So you must know where your lever for removal of that air or deflating that air mattress is. Air mattress, how does it work?
Pressure compression.
It goes
No. So the air mattress has got multiple cells. There are multiple cells. At any given moment, there is one group of cells that are inflated, one group of cells that are deflated. So it has differential pressure all through the body. Sometimes pressure is here, sometimes pressure is here, sometimes pressure is here. Are you understanding? So there are differential pressures that are created in that air mattress. It's not in one place, and that is how it works. So it inflates, deflates. Have you slept on an air mattress? It is very difficult.
Yeah.
It is extremely difficult because it's very, very difficult to sleep on it because it's uncomfortable. So what does this mean? If the patient becomes conscious and patient is very stable, take him off or him or her off the air mattress because it will become one of his reasons for irritation and sedation requirements. Okay, so the air mattress needs to come off. It's very essential if the patient becomes very conscious, because it's very difficult to sleep on an air mattress. It's very, very difficult. Okay, ये हो गया air mattress. That's about bowel and bed sores. right? Then I. What is I?
Indwelling catheter.
Indwelling catheters. So whenever you're looking at indwelling devices, it's actually indwelling catheters, which includes Foley's, central line, arterial line, PA cat, whatever is there. All of these devices, you are going to look for day of insertion. Day of insertion. Okay. The second thing, is the site clean? Is there any redness? Is there any exit site infection? Is there any tenderness? So these 5 has to be there on your notes. Okay. No redness, no tenderness, no exit site infection. That has to be there in your notes. So clear, clean, no redness, no tenderness, and no exit site infection, and day of catheter. Why is this important? Because in the CLAPSI bundle, what is the CLAPSI bundle? A CLAPSI bundle is a number of investigations that we use combined to prevent a CLAPSI. Whenever you have bundle, whenever you hear the word bundle, it means those particular interventions can't be done separately. It has to be done together. If you don't do even one of those interventions, the bundle is not complete. Okay, that it will not prevent CLAPSI. So in the CLAPSI bundle, one of the things that you want to do is assess the need for the central line. Assess the need for the central line. One of the bundle factors is that assess the need for the central line. So if there is a central line in place, can I remove the central line? Should be the first thing coming to my mind. It requires that. Okay, that's why I put the day there. Okay, because every day that a plastic remains in the body, there is going to be a colonization. Every day there is going to be a colonization which might later cause problems. Right? So this is about indwelling catheters. Right? And the last is D. What is D?
De-escalation.
De-escalation of antibiotics. De-escalation of antibiotics. Whichever antibiotics whichever you have started, have you de-escalated the antibiotics? That has to be there. Okay, day 7 of antibiotic, day 8 of antibiotic, day 9 of this antibiotic. Is it the right time to de-escalate? This question has to be asked daily in your daily rounds, because the biggest problem that we all have in the intensive care scenario is actually antimicrobial resistance pattern.
Yeah.
Okay, antimicrobial resistance is the biggest problem that we have, to an extent that the government is going overboard to actually prevent antimicrobial resistance as of now. Okay, we don't have new antibiotics coming in. We have to ensure that we give. Unfortunately, we are in intensive care where we don't deal with simple bugs. We're always giving very broad spectrum antibiotics because we are in that situation. Tomorrow nobody can come and say intensive care में requirements तुम लोग क्यों ऐसे क्यों कर रहे हैं? क्यों कर रहे हैं means है requirement है हमारा. But as part of the entire game, we also need to ensure that we de-escalate. So we use various kind of techniques to de-escalate. But you should always think, can we de-escalate the antibiotic? You should think that every day. Can we de-escalate? So when you see me taking rounds, I am actually telling this to myself. Can I de-escalate? If you hear me, what I'm saying, can we do this? It's important that you do this on a regular basis. Remember this, just like how a bundle works. Where is Niharika? She's not come today. Niharika nahi hai, no? There, no? A bundle. If you do 10 things right and do the 11th thing wrong, you are completely wrong. You understand? You may do 10 things alarmingly brilliantly, but there one thing going wrong will spoil everything. Similarly, in mechanically ventilated patient, all of the things have to be done together. All of the things have to be done together. All of the things. You cannot say that I have done everything else better. इसमें तो क्या बोल दिया? No. Everything has to be done well. If everything is done well, that is when you are treating this mechanically ventilated patient properly. Clear on this? So the entire mnemonic is fast hug BID twice a day. That's what BID बोलने के लिए BID बोलते हैं. So fast hug BID. This is a mnemonic that came in the 90s, and we are still continuing with that mnemonic. And you should be continuing. Every nurse in the ICU should know the fast hug BID. Every doctor in the ICU should know fast hug BID. Clear? Any questions on this?
Stratification.
Yeah.